Section 2 will endeavor to discuss the treatment of the whole person and also to introduce chronic pain phenotyping. Our learning objectives for this section are to discuss and understand chronic pain trajectories across the lifespan. Our second learning objective is to define and explore the biopsychosocial model of pain and its strengths and weaknesses. Our third is to discuss and explore the treatment of chronic pain from the perspective of the whole person. And finally, our last objective is to introduce chronic pain phenotyping. All this information about risk factors and how many people suffer from chronic pain and which demographics leads us to another important question. What happens to patients who suffer from chronic pain over time? Are these people doomed to suffer forever at the same pain intensity forever? In other words, we need to answer the question, what is the natural history of chronic pain? This excellent 2020 study by Gillette and cohorts aimed to determine the natural course of chronic pain in a large sample of patients over the course of 4 years. I should note that they did not account for those who underwent specific treatments, but only accounted for the fact that these persons were generally suffering from chronic pain. This study included 1,905 subjects. They measured pain ratings at different time points, activity limitations, work participation, depression and anxiety symptoms, recovery expectations, catastrophization, healthcare utilization, and sleep difficulties. This study by Gillette discovered 5 different trajectories. The orange line represents persistent mild pain. The green line represents persistent moderate pain. The blue line represents a fluctuation of pain, with the most common fluctuating pain being between mild and moderate intensities. The yellow line represents persistent severe pain. And finally, the purple line represents gradual improvement. While these trajectories seem to be stable over time, they are not static. Note that the authors of the study reported averages and that some patients did change trajectories over time. This means that we as clinicians should not give patients the false impression that they cannot improve. How might we swing people to other trajectories and or improve their quality of life? How do we treat chronic pain? Well, due to the high degree of individual variability of the etiology, nature, and presentation and risk factors associated with chronic pain, clinicians and scientists alike ascribe to the use of a biopsychosocial model of treating pain. The biopsychosocial model of pain was first described by the American psychiatrist George Engel in his seminal 1977 publication entitled A Need for a New Medical Model, A Challenge for Biomedicine. At the time of the article's publication in 1977, there was a schism looming in the broad field of medicine. On one side, you had the branch of psychiatry who was generally believed to be concerned with diseases of the mind. At that time, the field of psychiatry was regarded by many as pseudoscientific and a philosophical branch of medicine. On the other side was the biomedicine branch, who had a firm base in the biological sciences. It was believed by many that the field of psychiatry would do well to emulate its sister medical discipline by embracing a medical model of disease. In this regard, Engel, who was far ahead of his time, is quoted by saying, "I do not accept such a premise. Rather, I contend that all medicine is in crisis. Further, that medicine's crisis derives from the same basic fault as psychiatry's, namely adherence to a model of disease no longer adequate for the scientific tasks and social responsibilities of either medicine or psychiatry." Engel's thesis here and in this article that the dominant biomedical model of disease leaves no room for the social, psychological, and behavioral dimensions of illness, and provided several examples of the manifestation of specific psychiatric and medical diagnoses which manifested differently based on non-biomedical factors. His intent here was not to belittle biomedical factors and to magnify social, psychological, and behavioral dimensions of the illness as superior. Rather, his thesis was that all of these facets are necessary in creating individual presentations of disease. Engel's thoughts on the high degree of individual variability in the etiology, nature, and presentation of disease have made clinicians and scientists extend the use of the biopsychosocial model to the diagnosis and management of pain, which aims to integrate biological, psychological, behavioral, and social factors. The benefits of the biopsychosocial model, or the BPS model, is that it made us clinicians look for factors outside of peripheral sources of injury that may help in the diagnosis, prognosis, and treatment of chronic pain. Over time, however, numerous issues with the biopsychosocial model of pain became apparent. While implicitly understood, Engel does not explicitly map out how the individual biological, psychological, social, and behavioral component parts of the biopsychosocial model interact with one another to create disease presentation. How do the different aspects of the biopsychosocial model function together mechanistically to create disease? Simply put, Engel did not tell us how the biopsychosocial model works, only that it does. Additionally, over time, treatments have become increasingly siloed and remain separate and distinct from one another, when in reality, chronic pain patients likely require an integrated, interdisciplinary model of care, requiring some or all of the different therapies simultaneously. For instance, in the biological silo, this might include therapies such as injections, surgery, or even manual therapy. In the psychological realm, we have therapies such as CBT, or acceptance and commitment therapy, or mindfulness-based stress reduction, or meditation. From the social perspective, we have group programs or volunteering, which can act as potential treatments for chronic pain. Finally, in the behavioral silo, we have goal setting, gradual exposure, or modifications in order to improve one's function in their home or in their workplace. In reality, we need to create an individual treatment plan that includes all of these different treatments together based on the person's individual presentation. So in light of these challenges, what should we as clinicians do? To provide an integrated model of care for those with chronic pain, we must shift away from the silos and think about diagnosing and treating the whole person. Thinking of the whole person mutually considers all of the variables we have spoken about in this module without segregating them into their component parts. Furthermore, researchers, clinicians, and patients alike must understand that these variables are dynamic and interdependent and inseparable. To do this, we must be thorough, communicate, take our time, develop a trusting relationship, rule out sinister pathology, reassure, educate, and work with the patient to provide rehabilitation. So how do we direct the diagnosis and treatment of the whole person on an individual level? We have to satisfy a number of questions before we do that in our clinical encounter. The first is, what are the patient's needs and goals at the time of your evaluation? The second is, which contributors inherent to that person's pain experience are modifiable and which are non-modifiable? Regarding the existing variables in this patient that are modifiable, which do I, as a clinician, have the skills to help the patient modify? We should additionally be able to look beyond ourselves and ask the question, if I don't have the skills to help them, now what? Where should they go? This does not mean that we need to know everything about every form of treatment across the silos. Rather, it stipulates that we must know enough to recognize variables that are not within our scope or skill set and propose to the patient that they might require services above and beyond what you can provide. And finally, we must ask the question, does my treatment change if the person's needs and goals change, and if so, how? Now, this process might become daunting because there are over 7.8 billion people on the planet Earth. That means there potentially exist 7.8 billion permutations of the pain experience that we as clinicians need to be able to figure out. This is why the concept of phenotyping came to be. No, I don't mean to bring you back to grade 11 to study Mendel again. My intent by using the word phenotyping is to group people into clusters depending on specific features, including the dominant neurophysiological mechanism underpinning their pain, their historical timeline, their psychosocial history and status, individual patient needs and goals, and their response during the clinical evaluation. I should note that this is not condition-based. Two people can suffer the same condition and carry the same diagnosis, but still fall into different phenotypes. Here's an example of two patients with low back pain that started 1 year ago. And this slide was borrowed from a paper from one of our physiotherapy colleagues, Dr. David Walton from Western University in London, Ontario. On the right-hand side, you have a patient with right-sided lumbosacral pain. Let me take some time to describe what this image is telling you. These concentric rings mean that the individual variables stipulated have a different intensity in that person's pain presentation. In the middle, in the blue, you have low contribution. In the second ring, in the greenish yellow, we have low contribution. In the yellow, we have a moderate contribution. In the gold, we have a high contribution, and in the red, we have a very high contribution. And this person on the right side, as you can see, has some central nociplastic or some CNS variables about how their CNS functions and processes pain, which might act as a potential negative prognostic factor. They also score very high in emotional or affective contributors, and they also score very high in cognitive or cognitions or beliefs that might hamper their prognosis. On the left side of your screen, you might have a similar patient with right-sided lumbosacral pain. They might have a little bit of a contribution from socio-environmental aspects, but they score very highly on nociceptive physiological contributors, indicating that there is likely a tissue lesion that is highly associated with their pain experience. Me as a treating clinician, I would rather have the person on the left because they don't feature as many cognitive, emotional, affective, or CNS functional aspects that contribute to their pain presentation. So even though these two individuals have the same clinical condition of chronic mechanical right-sided lumbosacral pain, it's arguable that the person on the left has a more favorable prognosis than the person on the right. And conversely, that clinicians who might treat patients who are described as those on the right might have a more difficult time reaching the typical outcomes you're used to. So why phenotype pain? Well, what are the strengths of phenotyping? First, it enables prognostication for long-term recovery. Two, it enables flexible consideration of multiple variables. This is dependent on the skills of the clinician and the patient resources. Fourth, it enables the clinician to be honest about the limitations of their care. And this is important because we as clinicians should understand where a job begins and where a job ends. And quite truthfully, we need to be honest with ourselves and the patient about when we should include another practitioner in that person's treatment program. Fifth, it enables the design of an individualized treatment plan. And these are the various pain phenotypes that we're going to discuss throughout this course. Many ways to phenotype have been developed, but these are the 5 phenotypes that I have developed based on a marriage of evidence and clinical experience, and will make up much of the rest of our course. Just be aware of the fact that this serves as an introduction, and that if anything seems unclear after this, it will likely be explained in later modules. These pain phenotypes include a nociceptive dominant pain phenotype, which indicates that there's a high threshold peripheral sensory stimulation in the form of nociception that might be the dominant underlying cause of pain. The second phenotype is an inflammatory dominant phenotype, which is a peripheral sensitization from an inflammatory response. The third phenotype is a peripheral neuropathic dominant pain phenotype, whereby the potential source of pain is from peripheral nerve damage. The fourth phenotype that I include in this course is a nociplastic dominant pain phenotype, which includes functional changes in CNS processing of nociception. Last but certainly not least, the psycho-emotional dominant pain phenotype, whereby the dominant need for this patient is in the management of uncontrolled psychopathology, stress coping, and maladaptive thoughts. It is also important for clinicians to remember that a patient might have qualities of multiple phenotypes, but we as clinicians must determine which is dominant and provide treatment accordingly. And as you perform treatment, patients might move from one phenotype to the other. So what this means is that we need to do a thorough evaluation, consistently and repeatedly evaluate our patients. This will now allow us to identify the dominant pain phenotype at that time. It also enables us to treat modifiable risk factors or refer out to another treatment provider if warranted. And as stated previously, we must reevaluate and determine if the phenotype and patient needs change. So that way we can change our treatment as time goes on to suit the patient's needs. This thought process is nicely described by the amazing Annie O'Connor, who authored the book A World of Hurt, A Guide to Classifying Pain, a book which really highly influenced me. During one of her amazing courses, I heard Annie say, "Invest in reevaluation, not in treatment." This is because your thorough evaluation will tell you whether you can work with that patient and also what to do. Remember that over time, the needs of patients with chronic pain will change. You have to determine what those needs are and if you can help the patient manage those needs. If not, the patient might require the services of another professional with different skills than you, and that's okay. But this brings up an important question. What are the weaknesses of phenotyping? Well, the first weakness is that the patient might not have the resources to get the different treatments that they might need. What now? Many of the barriers for patients to get resources are real and often dictated by affordability and access in smaller communities. Sometimes these variables are modifiable, while other times not. We must try our best to help patients find resources, and many times their family doctor or general practitioner might be of great help. It is always best to communicate with the patient's primary healthcare provider. Second, what if the person falls into multiple phenotypes simultaneously? What now? It is inevitable and likely that patients will simultaneously fall into multiple phenotypes. Firstly, it is pertinent to ask yourself and the patient which needs are most important at that time. It is then important to focus on those needs and choose which is the dominant pain phenotype. As the patient's condition and needs change, the dominant pain phenotype will change too. That's why continued assessment is required. What if we as chiropractors just don't practice like this? It's not within our practice model. What do we do now? One need not change their specific practice nor give up a roster of patients. Clinicians must simply understand enough at a minimum to determine what their patients' needs are. And if those needs are not your services, try the best to recommend where they should go while not discharging your patient. Chiropractic care is inherently valuable. That patient might just need something else in addition to that. What if we as practitioners don't have the ability to communicate with other providers? What do we do then? In my personal practice, I've not found too many physicians or other healthcare providers that are not open to chatting if you reach out to them, egos aside, and with that patient's well-being at the forefront of your discussion. Keep it respectful, stay in your lane, and request their help and their opinion. Your colleagues in other professions are healthcare providers, same as you. It is pertinent to treat them as such while communicating findings and asking for their opinion. So in summary, 5 stable chronic pain trajectories statistically exist. While stable, it is possible for patients to change trajectories. The biopsychosocial model of pain aims to consider multifaceted aspects of pain, but also has shortcomings. One must consider the whole person. And that's what I really think that Dr. Engel meant in his original publication. Now, 7.8 billion people exist on Earth, making whole person treatment of every individual difficult. But clustering patients into phenotypes might provide clinicians with a little bit more direction on how to apply a whole person treatment. So that concludes our section 2. In our next section, we will discuss the history and physical examination of chronic pain patients.